फोन करूं सर को? Good morning, sir. There is a presentation. Shall we start? Okay, sir. I am just.
और आपको पता चलता विश्व वापस आ गए। हाँ ये लोग दोनों का वाला है ना भविष्य है ये वो लोग चलेगा आप लोग करते हो उस वक्त तो अभी क्यों किया जब स्टार्ट
मम आगे सर गाड़ी सर आ रहे हैं। अब मैंने पॉज कर दिया।
इन दोनों ने आप नहीं चाहते तो कोई नहीं चाहता मैं ये बोलना चाहती हूँ आपको गिफ्ट कौन देगा सर अरे मुझे लगा कि
म्यूट कहाँ से होते हैं?
तो पूरा टाइम उठी तो बस नहीं खड़ी अच्छा हाँ सर सर मैं हाँ जी ठीक है सर आ रही है नाली सर ये राउंड से है मुझे क्या निकालना है आप खुद बता दो
हम सिर्फ अल्कोहल और साइकोसिस डाल रहे हैं। अल्कोहल और साइकोसिस डाल रहे हैं।
शॉर्ट्स में देखो तो छोटे छोटे पहले दिन से बस
Mute concept. वो तो आगे बहुत अरे पता तू आता नहीं एक बार ब्लैकमेल कम्युनिटी पूरा ओनली बात थी खाली सब के साथ से पूछेगी शेयर नहीं किया था ठीक है मैम। Today I'm going to present on the topic glutamate and psychiatry. My moderator is Dr. Mujani sir. What is a neurotransmitter? Neurotransmitters are chemicals that amplify or inhibit the depolarization signal from one neuron to that of an adjacent neuron. The classical criteria for a chemical to be considered a neurotransmitter were synthesis in a presynaptic neuron, storage and release from the presynaptic neuron, binding to a receptor on a postsynaptic membrane, and removal from the synaptic cleft by reuptake or degradation. Neurotransmitters are released in a calcium-dependent fashion from presynaptic terminals and act on specific membrane proteins to produce biochemical and excitability changes in the receiving cells. There are at least 9 low molecular weight amines that serve as neurotransmitters: glutamate, acetylcholine, GABA, glycine, dopamine, norepinephrine, epinephrine, serotonin, and histamine. Synthesis of glutamic acid or glutamate. Glutamate is a ubiquitous excitatory neurotransmitter in the brain that can virtually excite nearly any neuron in the brain, hence known as the master switch. The concentration of glutamate in the brain is 10 millimoles, the highest of all amino acids, of which approximately 20% represent the neurotransmitter pool of glutamate. Given the excitatory effects of the glutamate, it is excluded from the blood-brain barrier. Glutamate in the brain is synthesized de novo from glucose through the tricarboxylic acid cycle, which generates alpha-ketoglutarate. The alpha-ketoglutarate receives an amino group via a transaminase reaction, converting it to glutamic acid. Glutamate is in equilibrium with alpha-ketoglutarate, and virtually all glucose entering the brain is cycled through glutamic acid. After the glutamate is released from the presynaptic neuron, it is taken up into the glial cells by excitatory amino acid transporters EAT. Several studies have described the loss of E2 protein and transport activity in the ventral horn in a myelotropic multiple sclerosis. After uptake into the glial cells, glutamate is converted into glutamine by the enzyme glutamine synthetase. Then glutamine is released by specific glial neutral amino acid transporter SNAT through the process of reverse transport and then taken up by the SNATs on glutamate neurons. Glutamine is then converted into glutamate by the enzyme glutaminase and is taken up into the vesicular glutamate transporters for further future release. Glutamate receptors. Glutamate receptors can be classified into metabotropic receptors and inotropic receptors. Metabotropic receptors are further classified into group 1, 2, and 3. Inotropic are further classified into AMPA receptors, kinase receptors, and NMDA receptors. All three groups of metabotropic receptors inhibit L-type voltage-dependent calcium channels. Group 1 and 2 inhibit N-type calcium channels. In addition, metabotropic glutamate receptors are reported to close voltage-dependent potassium channels, thereby slowing the depolarization and reducing excitability. The NMDA receptor has several unique features. First, the channel is blocked by magnesium and resting membrane potential. Thus, NMDA receptors are silent until activated AMPA receptors are sufficiently depolarized the neuronal membrane to relieve the Mg2 positive blockade. The NMDA receptor requires a simultaneous binding of two ligands to two separate recognition sites in order for the channel to open, that are NR1 and NR2. The NMDA receptor has been described as a coincidence detector because these three events must occur simultaneously for the channel to open. It becomes functional only when a sufficient amount of presynaptic glutamate has been released to saturate the receptor. Glycine and D-serine are released. The synaptic membrane is sufficiently depolarized to remove the magnesium blockade. The type of NR2 subunit affects the pharmacology and biophysics of the NMDA receptor. NR2A containing receptors are expressed primarily in the cortical limbic region of the mature brain. NR2B is expressed at high levels in the immature cortex and decreases with maturation. NR2C is expressed in the cerebellum. NR2D is localized predominantly to the cerebellum and midbrain brainstem. Memantine is an NMDA antagonist which reduces the abnormal activation of glutamate neurotransmission and does interfere with pathophysiology of Alzheimer's disease, improve cognitive function, and slow the rate of decline. Amantadine is a weak, non-competitive NMDA receptor antagonist. It is used in Parkinsonism and drug-induced extrapyramidal side effects, but its efficacy in this arena is questionable. Plasticity of glutamatergic neurotransmission. It is of two types: long-term potentiation and long-term depression. A brief period of intense stimulation causes increasing synaptic efficacy. This is known as long-term potentiation. The long-term depression is a period of stable low-frequency stimulation of the glutamatergic axons resulting in persistent reduced efficacy of the synaptic neurotransmission. Conditions resulting in blockade of LTP in the hippocampus are associated with impairments in the acquisition of new memories. Key glutamate pathways in the brain: cortico brainstem, corticostriatal, hippocampal striatal, thalamocortical, corticothalamic, corticocortical direct, and corticocortical indirect. Alcohol and glutamate. Alcohol enhances inhibition at GABA synapses and it reduces excitation at glutamate synapse, producing an overall depressant effect. It acts as a presynaptic metabotropic glutamate receptors and presynaptic voltage sensitive calcium channels to enable glutamate release. Alcohol may also have some direct or indirect effect on reducing the actions of glutamate at postsynaptic NMDA receptors and at postsynaptic metabotropic glutamate receptors. Ecamprosate, widely used as an anti-craving drug in cases of alcohol dependence, it interacts with both glutamate system to inhibit it and with the GABA system to enhance it, a bit like form of an artificial alcohol. It has direct blocking action on certain glutamate receptors, particularly the metabotropic glutamate receptors, thereby mitigating the glutamate hyperactivity. The NMDA glutamate hyperfunction theory of psychosis suggests that psychosis may be caused by dysfunction of glutamate synapses at specific site, a certain GABA interneuron in the prefrontal cortex. Dysfunction can be caused by neurodevelopmental problems in schizophrenia, drug toxicity in ketamine and phencyclidine abuse, and neurodegenerative problems in dementia. Interference with normal neurotransmission at sites between glutamate and GABA neurons due to neurodevelopmental abnormalities in schizophrenia causes loss of function of inhibitory GABA interneurons. Thus, glutamate neurons become disinhibited and hyperactive. Ketamine and phencyclidine are NMDA receptor antagonists and block the same sites on GABA interneurons as hypothesized for schizophrenia. In neurodegenerative disorders, accumulation of amyloid plaques, tau tangles, Lewy bodies, or stroke knocks out the neurons as the disease progresses. Linking the NMDA glutamate hyperfunction hypothesis of psychosis to the dopamine hypothesis of psychosis. In patients with dementia-related psychosis, the neurodegeneration progresses in such a way as to knock out some glutamatergic pyramidal neurons and GABAergic interneurons in the prefrontal cortex while leaving other glutamatergic pyramidal neurons intact. When an NMDA hypofunctions, the glutamate becomes hyperactive, which further enhances the release of dopamine, thus causing the positive symptoms of schizophrenia. And there is a second population of glutamate interneurons that project to a different set of ventral tegmental area neurons, that is mesocortical. This circuit inhibits dopamine release, causing negative cognitive and affective symptoms of psychosis.
Questions? Questions?
NMDA hyperfunction causes glutamate hyperactivity, which enhances dopamine release, thus causing the positive symptoms of schizophrenia. And there is a second population of neurons which project to a different set of VTA neurons, that is a mesocortical area. This circuit inhibits dopamine release, causing the negative symptoms of schizophrenia.
First two figures 1 and 2 are related, and second two figures are related, right?
Yes, sir.
So first that shows the dopamine
Positive symptoms of schizophrenia.
positive psychosis.
Yes, sir.
So there is a hypofunction in the SLK NMDA receptors, and then that leads to disinhibition of that, right?
Yes, sir.
And second is the mesocortical part.
Yes, sir.
क्या होता है mesocortical? That is very important. प्रेजेंटेशन के लिए जब भी आओ तो ये सब चीजें आपको कभी एक्सप्लेन कर पाओगे आप and it is affected in multiple symptoms. So what is the problem in psychosis related to the hypothesis related to glutamate?
So there is an NMDA hyperfunction in the prefrontal cortex.
Hyperfunction.
Hypofunction. Yes, sir.
So we require an NMDA receptor analogs.
Yes, sir.
Stimulation.
Yes, sir.
So in the first thing, it's a direct inhibition to the excitatory glutamate. that causes dopamine hyperactivity. And in this negative mesocortical pathway also, the hyperactivity, glutamate hyperactivity causes GABA
interneurons to inhibit dopamine release.
Maybe we could have opened this, two slides. Speaking like any other questions? Comments? In PTSD also glutamate. Memantine, how does it happen? It's an identity receptor. That is why it is efficacy in both we use. Dementia में भी use करते हैं, even in alcohol, withdrawal we use. This is also here, memantine of level. Right. What is the most common inhibitory neurotransmitter in brain? Glutamate, psychiatry, or
GABA.
most of the sedative medicines they act. Okay. Presented well for the first presentation. It was concise. Maybe you can just slow your pace. Okay, when you are presenting, you need to enjoy it a bit, like you're teaching. Don't think that your assessment is being tested. Whatever you want to say, you need to express it. Okay, like for the first time, it is okay. You did very good. So for the future, you can say that how you can improve. Like you have the content, then how you can improve your say. Try to make eye contact with the audience, see what they're saying. Okay. Similar, but the slides are good and presentation was good. Content was okay. So just build on that. Okay. Now the next step. तुम लोग एक दूसरे की